Good morning, good afternoon, and good evening. Welcome back to Peripheral Joint Mobilization. Again, the last video was cut a bit short. I apologize for that, but now we're back and ready for action. Before we actually get to part 5, I would like to be discussing this big book of boo-boos. So, I didn't really get to discuss this in the last part because I know it would not take up 5 minutes. So let's discuss it now before I start because the last part is fairly I'm just sharing you a table, really. It's just things you gotta memorize. But okay, progression of treatment. So this is different from, I don't know, this is a more specific progression of treatment as compared to the one I provided in, I think, part 3, wherein PJM stretching ROM exercises. So this is different. Let's go through this one by one. Again, this is taken from Kistner. So you get a patient and you want to perform some other type of intervention, but due to pain in the joint, you can't. So you base it off this table. In every treatment, you must always start with a grade 2 joint traction and resting position. RP means resting position. DC means discharge. I think those are the only two acronyms here. So yeah. So you start with a sustained grade 2 joint traction. So what does that mean? That refers to Carlton board. Remember this, remember this, remember this. Jingle jingle, you remember this, right? Jingle jingle jingle, you can do it. Okay. I'm going to. Sorry about that. I got caught off again. Again, so pay attention to me. Jingle jingle, jingle jingle. Okay, so first treatment, you apply this. Why do we need to apply this? So that we can see how the patient responds to the treatment. If it gets, now we go to day 2, patient response. Day 2 could refer to the second day in which they apply the treatment or the second session, because sessions don't really occur usually in consecutive days. Sometimes it can occur per week or some sort, it depends. But usually, day 2, you determine. Let's go to this one first. So, jingle, 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 pay attention. So, increased pain or inflammation. If the patient, upon being applied with a grade 2 joint contraction, joint play distraction in the resting position, and they experienced, sir, ma'am, they, them, they, them, him, her, she, who, I don't know, it hurts, it still hurts. Why didn't it work? I thought you were supposed to be better at your job, but you're just useless little. Okay, jingle, jingle, right. So, anyways, they got a bit increased. Okay, sorry. Dial down. Got increased pain. What do? You apply grade 1 oscillations in resting position to control the pain. Control the pain. What is grade 1 oscillations? You ask? This one. Boom. 1423, 1423. Small amplitudes are just this. You apply this, brother. You apply this. Okay. Okay, so let's say I applied it, yeah, on day 2. What do we do next? So you check again. If they still feel painful, then you apply grade 2 oscillations. You increase the amplitude. Large amplitude rhythmic oscillations for 2 to 3 oscillations per second, 1 to 2 minutes for the duration. Now, if they feel on the third day of Christmas, they be like, thank you, it feels better now. They feel same or they feel better. You go here. Okay, now let's go here. Okay, jingle jingle. Pay attention to me. Jingle jingle, jingle jingle. Okay, let's go back here. So let's say first day of treatment. Oh yeah, I apply grade 2 joint play distraction for you, ma'am, or sir, or they, them. And you go day 2 patient response, and they were like, huh, that feels a lot better, hon. Or it feels the same. So now you choose. If it's the same, you would go here. Wait, what? Wait. Okay, if you go here, you go here. Sorry, I got a bit confused. Even I'm getting confused. Okay, so if it's the same, you applied a grade 2 traction or gliding in resting position to maintain joint play. What is grade 2 traction? Jingle, 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 jingle. It's Carlton board, right? Grade 2 traction, tighten. You tighten. You stretch it until tissue resistance for 7 to 10 seconds usually, and then relax for a few seconds in between. Okay, and then you get to the third day of Christmas again, and you check. Okay, ma'am, sir, they, them, what do you feel? They'll be like, I can move it on my own, hon. Discharge them. Good job. You're a good physical therapist. Jiggle, 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 jiggle. Pay attention to me. Okay, let's go to the other part. So let's say they didn't feel the same. They felt ultra mega better. I'm like, I'm better than everyone. Yeah. I mean, I'm gonna burp. Give me a sec. Just kidding. The burp did not come, and I feel very disappointed. Okay, they feel better. Now you apply sustained grade 3 techniques to increase joint pain. What is sustained grade 3 techniques? Jingle, jingle. This thing. This thing is sustained grade 3 techniques. This. Stretch it. Alright, alright. Now, if this is where it gets really complicated, guys, okay? Because you have to apply the concave convex rule. So I'm gonna speak to you in a very calm manner so that you won't panic. If gliding is restricted in if gliding in restricted direction is painful, glide in the painless direction. Alright? So let's say your patient has limited shoulder flexion. In shoulder flexion, the arm moves anteriorly. The rolling occurs anteriorly. The convex humeral head is the one moving, meaning the sliding occurs posteriorly. Right? In the peripheral joint mobilization, if there's limited shoulder flexion, what you would usually do is you would do it posterior gliding, right? So if, let's say, they are restricted in posterior gliding, and you're doing posterior gliding to increase shoulder flexion, because according to Kistner, that's what you do when you're limited shoulder flexion. You want to do PJM. If there's pain in posterior gliding, you could guide anteriorly. You get me? Okay, that's why it's very important you have the concave convex rule mind in your mind. Okay. However, if it restricted without pain, glide in restricted direction at the end of available range. Meaning you could say that use the same example, posterior gliding for PJM for to increase shoulder flexion. If you can perform posterior gliding on the patient, but there's no pain, but the movement is still restricted, you could try applying a grade 3 technique until the end of available range. So basically until here. So you go further, but don't break the joint, just like a little bit further. You could try applying more force. However, if it's still a bit tight, but they can tolerate the pain, I mean, there's no pain at all, and they're doing better, you could progress by adding rotation prior to traction or glide, meaning you could internally rotate the shoulder, externally rotate the shoulder before you apply traction or gliding. Okay, that makes sense, right? Okay, so this is basically the summary of it. I hope it makes sense. If it didn't, my tip really is to just keep reading it like a maze. Just keep reading it like this. You know those one horror game in the 2010s where you get an arrow and then you try to, avoid the walls, and then if you fail, you're gonna get jump scared by a scary face. Just imagine you're playing that, but this time you're actually following the lines because you need to read the text. So just keep reading it. Refer back to the Kistner techniques and how this PJM work, because I'm not going to be discussing how to apply PJM, alright? I'm just discussing the theoretical aspect, the lecture aspect. Okay, now we go to jingle jingle, jingle jingle. Beautiful keys, right? We go to part 5, capsular patterns and positioning. So this is very, very straightforward. You just memorize. I'm sorry. I know it's a lot, but you just need to memorize it. I would say maybe a tip, just memorize the big joints. These ones, not really. You don't really apply PJM to these ones. Uh, Although you need to memorize all of these because you will be treating all of these. But for now, for PJM, this is important. Oh, that's not important. No, no, no. X. No PJM to the cervical spine unless you're like super trained. So we got glenohumeral, sternoclavicular, acromioclavicular, especially the elbow joints. Yep, these ones, this one, not so much. So long as you get the mid-carpal and the CMC joints, then you're fine. These ones, not really. Nope. Yeah, hip is very important. So I guess we're going to the big joints here. And knee, yes, talocrural, yes. Distal tibifibular, very difficult to manipulate, so not really. Yep, this one definitely. And the tip here is that the fingers and the toes really are just same thing. So you just apply the same thing there. But yeah, still memorize their capsular patterns. Oh, I haven't explained what capsular patterns are. Basically, capsular patterns, as you can see here, movements are listed in order of restriction. So for example, if you have an affectation of the hip, you would lose hip flexion. That's the first thing you could lose. If you have an affectation of the metacarpal or the wrist joint, you would have equal limitation of flexion extension. If you had an affectation of the knee joint, tibiofemoral, you would have flexion as restricted motion first. So this basically just describes the pattern in which joint movement is restricted if a patient experiences a condition or an impairment in these joints. Eh? Let's go to the last part. Come on, come on. Okay, this one. I'm just showing this. I'm not gonna explain it because this is also a lot of memorizing. So these just basically show what are the closed pack position and the open pack position of joints. I made these, so yeah. If there's any incorrect information, I apologize. But these are just my own makings. I took references from books, but yeah, I might be dumb. So just these are just basically memorizing of these. I put the capsular pattern here so you could easily get it. Usually when you memorize capsular pattern, you could visualize them like this, so greater than signs. You could see, oh, this one is the first one gone. It's like, a game. Which one's first one gone? Which one's the first character that's gonna die? So this is also like the same. These are basically just things that you gotta memorize. So, PJM. What are my last thoughts about it? It's beautifully complicated, I think. It's definitely not as difficult in terms of theoretical. If we're talking about application, yeah, it's very difficult. I think the most challenging part of it is the grading system, especially the progression of treatment, because you could really slip up, test people make tests could, provide some tricky questions, and you'd be like, wait, what do I provide to this patient? It's very difficult that way. But I think if you just familiarize, actually, no, it's not even a thing. Okay, here are the big actual tips that I'm going to provide. Memorize the capsular patterns, memorize the open pack and closed pack positions, memorize the progression of treatment, memorize the grading systems, Maitland and Haltenborn. Understand the concave convex rule. Be very familiar with anatomical bone surfaces so you know with convex, concave, and you'd be very ready for exam. But again, exam knowledge and exam strategy is very different. So just be careful when you're trying to answer exams that involve PJM. So thank you for accompanying me in this lecture. I know it was very, very chaotic, and also I'm kind of tired too. I need to memorize all of these. I didn't just show you that slide because it's for pretty stuff because it's pink or anything. No, I show you that because I also need to memorize it, and I'm actually gonna be very sad. For me though, I'm just gonna memorize the open back positions because that's one of the most important ones and the capsular pattern. Closed back positions, I'll see what I can do with that one. So that's the end of this lecture. I hope somebody learned something. Yeah, I'm gonna go now.